Thank you, Dr. Hayat. And finally, my battle. I will adopt the opinion of doing scleral fixated IOLs in pediatric aphakia with no capsular support. Okay. Of course, many researches had been done to differentiate the iris claw lens and scleral fixated IOLs in the pediatric age group. Many researchers, and the last meta-analysis was done in 2024, and they all concluded, as just Dr. Hayat mentioned, that they are comparable, but they put few conclusions. There is the summary of the conclusions, that although the scleral fixated IOL takes more time, surgical time, and relatively challenging surgery, but it has a better visual outcome and less astigmatism, and it is suitable for most cases, especially traumatic with iris lacerations, and it avoids suture-related complications in sutureless technique. And although the iris claw lens is an easier technique and has less operative time, but it might have many complications after surgery. Sometimes you might have a post-operative inflammation because you're touching the iris many times. You might have a long-term disinclavation and the iris atrophy because pediatric age group will have a long lifespan, and you might face many dislocations of the iris claw lens, although the endothelial loss, and of course we all know that many in the pediatric age group angle anomalies are very common and might cause glaucoma, and it requires intact iris which is not present in some traumatic cases, and it affects pupil dilatation. So I prefer to do the scleral fixated, the modified technique, sutureless scleral fixated IOLs, the Yamani technique, and already in my institute we had done a study on 26 child from 3 years old to 16 years old doing the Yamani technique, and the technique was very reproducible and very productive in all the cases, has fewer complications, but the idea is how to simplify the scleral fixation IOL technique in pediatric age group to get familiar with it and avoid its complication. This is the main idea. Preoperatively in pediatric age group, if you gonna make you want to use the Yamani technique, please do thorough retinal examination to exclude there is no breaks or degeneration. And there is a very important point, because the pars plana is very important part in this technique. So you have to examine the peripheral the peripherous indentation if you have any cases of persistent fetal vasculature, any cases with anterior segment degenesis in iridia. Sometimes in rare cases you have absent pars plana, and in some other cases you have a dragged retina anteriorly in cases of persistent fetal vasculature. And this is a video was recorded by my colleague Dr. Mariam Rifai, and she reported the anterior dragging of the retina of the aura to the pars plana. So if you make the puncture or the puncture in the aura, you will make it in the aura and in the retina instead of the pars plana, and you will get a future retinal attachment in this baby. So you have to examine the pars plana to ensure you have intact pars plana before going for Yamani technique. Another point, you have to be ready with all the required instruments. If you're not ready, please postpone the case. You need to have the anterior segment forceps, the cautery, and the insulin syringe is very important in our technique. You need to know the perfect needle to use for each lens. We can use the needle gauges from 27 to 30. The Acrisoft IOL has a thin haptic, but if you gonna use 29 or 30, just make sure they are thin walled. Another very important point is please try to make docking before going into your surgery, before the surgery and before going inside the eye. Try docking and try put the haptic in the needle, because sometimes and some needles have a manufacturer error, and so and to be more relaxed in your surgery. I will show you a surgery in a phakic 3-year-old boy with my modified technique. The marking is very important, and don't underestimate the power of marking before you start, and planning before you start your thing. You have to mark for the anterior, the opening for your anterior segment forceps, the plain incision, the opening for the AC maintainer, the two openings that you will enter inside the eye. They have to be on the same meridian, horizontal meridian, perpendicular to the meridian of the main incision and just above the horizontal meridian. As you can see, I made my marking. I just will inject the IOL in the anterior chamber, and I will show you my few modifications to make it easier. We all know that in pediatric age group, the sclera has a low scleral rigidity, and so you have higher incidence of slippage of the haptic in the eye. You have to make sure that you had a quite a good lens, a perfect lens of the tunnel to avoid just 3 minutes, please. Just 2 minutes. You have a good tunnel to avoid making a fistula and doing short tunnels with higher risk of slippage. And also you need to make sure that when you enter the eye, the bevel of the needle is up. So you can get the bevel of the needle is up inside the eye. After you get out the haptic, please stop the irrigation. And this is my modification, just to make a suture around the leading haptic to be more relaxed and less stressed while doing, and to avoid the retraction of the leading haptic because of the high scleral rigidity, and then start to implant the other needle. To use the other needle, please make sure the bevel is up, to have it up when you get it outside the eye, and make your docking more easier. Please, the good length of the tunnel is very important. As you see, I leave the trailing haptic outside the eye, and I try to make docking outside the eye to feel more less relaxed. Just notice this is a very small eye. It's not the large regular adult eye. So you need to have few steps to make the technique easier and to be more relaxed and has a productive technique. So after you get out the haptic, please stop the AC maintainer and start make your flanges. In the pediatric age group, I prefer not to bury the flanges deep into the scleral tunnel. I need to see them under the conjunctiva, under the tenon. Why? Because I might have any refractive surprise, and I need to make IOL exchange in those cases, so I can make this IOL exchange. I would have more time to mention more tips, but we have just 6 minutes, and thank you.